This video is for educational purposes only and does not replace official training, local protocols, or medical advice. Always follow your specific agency guidelines and medical control. At its core, D-dimer is a fibrin degradation product, a measurable fragment left behind in the bloodstream when plasmin cleaves a cross-linked fibrin clot. Instead of telling us where a clot is, it acts as a global biomarker for active coagulation and subsequent fibrinolysis clot breakdown. In acute and critical care environments, understanding how to interpret this value, along with its diagnostic limitations, is essential for guiding clinical pathways. 1. Significance in emergency medicine, the power of the rule-out. In the emergency department, ED, the D-dimer assay is a cornerstone tool, but it is notoriously misunderstood. It possesses high sensitivity but exceptionally low specificity. The diagnostic rule. What it can do: safely rule out venous thromboembolism, VT, which includes deep vein thrombosis, DVT, and pulmonary embolism, PE. A negative result combined with a low pre-test probability means you can safely bypass expensive or high-radiation imaging like a CT pulmonary angiogram, CPA. What it cannot do: it cannot rule in a diagnosis. A positive D-dimer simply indicates that fibrin is turning over somewhere in the body. Clinical confounders, causes of false positives. Because fibrin deposition and lysis are tied to the systemic inflammatory response, elevated D-dimer levels are common in conditions completely unrelated to VT. Sepsis and severe infections, trauma and recent surgery, malignancy, advanced age, pregnancy, risk stratification and age-adjusted cutoffs. To prevent reflexive overtesting and unnecessary imaging, emergency medicine relies on clinical decision tools like the Wells criteria and PERC, pulmonary embolism rule-out criteria, to establish pretest probability before ordering the lab. Furthermore, because baseline D-dimer levels naturally rise as we age, standard cutoffs can lead to excessive imaging in elderly patients. Modern emergency medicine applies age-adjusted D-dimer cutoffs for patients over 50 years old to improve specificity without sacrificing safety. Standard unit check. Ensure you know whether your facility uses fibrinogen equivalent units, FEUs, or D-dimer units, DDUs, as FEU values are roughly double the mass of DDUs. The formula: 4 FEUs for patients over 50. The adjusted negative threshold is age times 10 nanograms per milliliter, e.g., an 80-year-old patient's negative cutoff is 800 nanograms per milliliter instead of the standard 500 nanograms per milliliter. 2. Impact on extended critical care transport, CCT. For a flight or ground critical care paramedic executing a long-distance transfer, the D-dimer value isn't typically used as a primary standalone diagnostic tool in the back of the rig, but it provides crucial diagnostic context and dictates your monitoring priorities during transport. Contextualizing the sending diagnosis. When receiving a patient from a critical access hospital or a freestanding ED, reviewing the initial lab panel prepares you for potential downstream complications. The sepsis/DIC track. In severe sepsis, a massively elevated or rapidly rising D-dimer is a hallmark warning sign for disseminated intravascular coagulation, DIC. If you note this on the chart during an extended transport, your focus shifts to managing widespread microvascular clotting and systemic consumption of platelets and clotting factors. You must anticipate sudden hemorrhagic complications, monitor for microvascular ischemia, e.g., assessing distal perfusion and renal output, and have volume or blood products ready if targeted by your protocols. Evaluating the subsegmental PE patient. If a patient is transferred for a suspected or confirmed PE with a borderline or marginally elevated D-dimer, it suggests a smaller, lower burden clot. Conversely, a sky-high D-dimer associated with right ventricular strain on an echo or ECG points toward a massive or submassive clot burden. Managing active infusions. During extended transports of confirmed VT patients, you are frequently managing continuous targeted therapies. Anticoagulation titration. Patients are often maintained on an unfractionated heparin drip. While you will monitor APTT or anti-XA levels rather than D-dimer to titrate the infusion, understanding the initial clot burden helps you watch for signs of acute clot propagation or sudden respiratory degradation. Thrombolytics. For unstable, massive PE patients being transferred post-tissue plasminogen activator, TPA, administration, the D-dimer will be profoundly elevated due to therapeutic clot breakdown. Your primary clinical focus here transitions completely to strict bleeding precautions, maintaining pristine line security, and continuous neurological checks to detect intracranial hemorrhage.